Nitroglycerin. As a reminder for EMT basics, it is within your scope to assist patients with their own prescribed nitro. ALS can administer initial doses without base contact. So what does nitro do? Nitroglycerin is a vasodilator acting on both the peripheral venous system and the coronary arteries. How it works. Nitroglycerin forms free radical nitric oxide. In smooth muscles, nitric oxide begins a chain reaction involving mitochondria, dephosphorylation, and other big words, which lead to smooth muscle relaxation, particularly in the smooth muscles surrounding veins and coronary arteries, or the tunica media. This chain reaction, in effect, injures the muscle cells, forcing the muscles to relax. While this reaction is good in an acute setting, since it relieves symptoms, patients who chronically use nitroglycerin develop a tolerance or a state that nitro doesn't work as well as it should. This is because the smooth muscle cells have been chronically injured and are less responsive. Tolerance can develop within 24 to 48 hours of continuous administration. At the cellular level, nitroglycerin causes smooth muscle relaxation. Looking more at the big picture, nitro causes muscle relaxation around the body's veins and coronary arteries. Let's look at what effect that has. When the body's veins dilate, they become larger, and blood within the circulatory system can pool there, reducing the amount of fluid returning to the heart with each heartbeat. This reduction in preload reduces the work the heart has to do, which in turn reduces the strain and oxygen demand on the heart muscle. Additionally, if the patient is experiencing pulmonary edema, this extra space in the veins will accommodate some of the fluid that was otherwise being forced into the lungs. On the coronary artery side, nitroglycerin relaxes the smooth muscle surrounding the coronary arteries, causing them to dilate slightly. In the case of angina, an incomplete blockage, or infarction, a complete blockage, nitroglycerin may dilate the artery enough to allow some blood flow distal to the blockage. So when do we use nitro? We use it in hemodynamically stable patients, that is, patients with a blood pressure over 100 millimeters mercury systolic with no active bleeding, who are experiencing chest pain believed to be of cardiac origin, or pulmonary edema from congestive heart failure. Do not use nitro if pulmonary edema is from non-cardiac causes, such as high-altitude pulmonary edema or adult respiratory distress syndrome. So when don't we use nitroglycerin? We don't use nitro if the patient has a hypersensitivity to it. We don't use it if they've used a phosphodiesterase 5 inhibitor or erectile dysfunction drug within 24 hours. We also do not use it if the patient has an increased intracranial pressure or a cerebral edema. When do we use nitro with caution? First case is a right-sided MI. If the right side of the heart is not functioning adequately, a patient's circulation is dependent on preload to the heart. This preload that passively flows into the right side of the heart is then available to continue circulating. If excess preload is taken away and the right side of the heart is unable to adequately move blood, this relatively passive flow of blood through the right side of the heart will decrease significantly. Administering nitro has the possibility of rapidly decreasing the preload. While this is desirable in left-sided MIs, as it reduces workloads, it can be very detrimental in right-sided infarctions. In an ideal world, we'll try to obtain a 12 lead prior to administering nitro. However, since paramedics and EMTs are permitted to administer or assist with nitroglycerin, this is clearly not the case every time. Generally speaking, however, right-sided infarctions present with a lower blood pressure and are less likely to be considered a candidate for nitro. ALS can mitigate some of the detrimental side effects by giving fluid boluses to patients whose blood pressure drops significantly after nitro administration. Another case that we want to use nitro with caution is borderline blood pressures. Nitroglycerin is contraindicated for patients with a blood pressure below 100 millimeters mercury. However, since we expect nitro to drop blood pressures, patients with a blood pressure slightly above 100 should be treated with caution. If possible, obtain a 12-lead EKG prior to administration due to the possibility of a right-sided MI, and or have IV access prior to administering nitro. So what can go wrong? Hypotension is our biggest side effect and is seen in about 4% of patients. Severe hypotension and shock may occur even with small doses, and we may also see orthostatic hypotension in these patients. Patients may faint or experience a syncopal episode. This is generally related to hypotension. We can also see headaches. We have a higher occurrence with nitro patches or ointments versus sublingual administration. Also may see peripheral edema and dizziness. Nitro can be absorbed transdermally, so if you come in skin contact with nitro paste or holding nitro tablets in your bare hands, you may also experience some of these same symptoms. With sublingual administration, onset is usually within 1 to 3 minutes with a peak effect of 5 minutes. Total drug duration is about 25 minutes. In Yosemite, nitro is carried as a sublingual tablet, 0.4 milligrams, that we can administer up to every 5 minutes. We can give a maximum of 3 doses before medical control consult. If a patient continues to be hemodynamically stable and nitro is effective at reducing patient's symptoms, medical control is likely to approve further doses. Yosemite EMS does not permit nitro administration without medical consult to kids. However, there may be situations, almost always with pediatric patients that have congenital heart defects, where nitroglycerin is appropriate, and calling into medical control is our best option. There are no adverse side effects specific to pediatrics with nitroglycerin. Nitro is a class B/C drug depending on the specific product, meaning that there has either been no evidence of risk in animal studies but results having been confirmed in humans, or that risks cannot be ruled out. Nitroglycerin does have a relaxation effect on the uterus, and there are some OB emergencies that nitro would be administered for in a hospital setting, such as preeclampsia with pulmonary edema. In 2017, nitro was administered 10 times in Yosemite. We'll now run through a short scenario. You may want to open the associated Google form quiz. The question posed in the scenario are part of the short quiz. As a reminder, the quiz does need to be submitted for CE credits for this training. So you're dispatched to a 57-year-old male with chest pain on the Mirror Lake Trail, approximately a quarter mile from the paved surface on a warm summer afternoon. When you show up, he's sitting on a rock, appears pale and diaphoretic. His airway's patent, seems to be breathing slightly rapidly, and has no noticeable bleeding. His skin is pale and diaphoretic, and his chief complaint is chest pain. Running through our OPQRST, our onset was approximately 45 minutes ago. A patient stated that the pain started near the top of the paved surface hill, then increased as he continued walking. It's decreased slightly since he's been sitting. He is not sure if that's from rest or from the nitro he self-administered. The patient describes his pain as a squeezing feeling inside his chest, denies any radiation to other body parts, and says that it is currently a 5 out of 10, though it was an 8 out of 10. Patient reports the pain started about 45 minutes ago. Patient self-administered 2 nitro tablets approximately 40 and 30 minutes ago, with slight decrease in pain after each one. For our sample assessment, signs and symptoms. Our signs are patient appears pale, diaphoretic, and has a somewhat rapid pulse. Symptoms reported are squeezing chest pain and a slight shortness of breath. Patient denies any allergies. His current medications are nitro, baby aspirin daily, atenolol, methotrexate, and Crestor. Patient states that he regularly sees his doctor and has a history of stable angina. His doctor prescribed nitro tablets that he takes approximately once a month on average when he experiences chest pain, always after exertion. His other medication he has taken as prescribed. Past medical history includes stable angina, high cholesterol, and psoriasis. The last meal was a delicious picnic lunch. He has been hydrating appropriately all day. Vitals, blood pressure 126/66, pulse 106, respirations 18, statting at 95 on room air. So for your questions on the quiz, fill out up to the appropriate level. So basically you just need to fill out these 4 questions. AEMTs, you'll have to do these in addition to the AEMT questions. So for BLS considerations, should you administer aspirin? And at what dose would you administer it if the patient has taken his prescribed 81 milligrams of baby aspirin that morning? Can you assist with another nitro tablet? Should you administer oxygen? If so, how and at what rate? And if ALS is not available to take this patient off your hands, what are your transport options? For AEMTs, would you take the time to get an IV access before administering nitro? Would you consider other pain management options such as fentanyl, ketamine, Toradol, or Dilaudid? What are your transport options? And would there be a situation where this patient would get a fluid bolus? And for our paramedics playing along today, what is the priority of the 12 lead EKG? Are you going to be carrying the monitor up the trail to the patient, or will you wait till the patient is back in the ambulance? Thanks everyone for playing along. Make sure you submit the quiz in order to get the CE credits. And I will be sending out the form probably in about a month after to give everybody ample time to take the training.